All right, welcome everyone. I'll do a quick little intro and gushing because we are so fortunate right now to have some of our, one of our many esteemed faculty from the IUCD program. This is actually the first time I've had the opportunity to meet Joseph. We've been emailing back and forth. I know, so it's wonderful. Thank you so much for being here. When we put out a call for presentations, and Joseph replied right away with this topic and thought this is fantastic and really important to bring to the community and to the discussion in general. So without further ado, we want to hear from you. So Joseph, the floor is yours. Thank you so much for being here.
Oh, thank you. I must not have known what I was getting into, having just jumped into it without asking any questions, right?
But that works out well for me. You just say yes and then we'll go.
I figured go ahead and say yes and agree to it. And if we see any red flags, I could always jump ship. And there were 0 red flags. So thank you for
perfect.
Thank you. A wonderful introduction and wonderful organization of the conference. I love it. It's great. Let me get my screen share going and then we can have some visuals to work with. And just give me a second. Of course, I had that all set up and now it's disappearing. So let me reopen that file. Try this again.
It's that time of day, I think, when Zoom gets tired.
Real, what's going on? Something bugs in the machine.
Mm-hmm.
I blame it on the technology.
Mm-hmm.
Let's see. All right, I'm seeing it on my end. Now let me see if I can let you see it on your end. And we'll get there. There it comes. Okay. Beautiful. Okay, can you all see my presentation now?
Yes. Yep.
Okay, great. Yeah, thanks so much. I am Joseph Constantine. I've been a speech language pathologist for over 30 years. Most of that time I've spent in universities and university clinics, so I call myself a clinic rat or a lab rat sometimes because I've spent so much time in research labs and clinical intervention programs. And so my perspective is, from a professor and a teacher scholar who has spent many years training students using, the current terminology in speech language pathology and education. And I thought, based on sort of popular topics that have been popping up lately, and just recently in the field of communication sciences, I haven't seen many talks like this. So I thought, well, maybe I should do this talk. I haven't. So I'm taking the bull by the horns, so to speak, and I'm using drawing from my experience and drawing from what I know about, historically how terms have developed and been used in healthcare settings and education settings for individuals with communication differences. Okay, so that's my basic introduction of me. This is the title page. So the title is Labels, Misperceptions, and Neurodivisiveness Across the Human Communication Spectrum. One of the sort of motivating factors in thinking about this topic for me was the current trend in using the term neurodiversity, and my personal reaction, and I will be sharing personal opinions, so do warning, I will be sharing personal ethical and clinical professional opinions, based on my experience. I have found that in some cases the term neurodiversity itself can be divisive in terms of trying to look at, well, if there's such a thing as neurodiversity, that's well and good, but at the same time, are we creating separate categories of neurotypical versus neurodiverse individuals that perhaps aren't really serving us as well terminologically as we would like them to be? So that's part of what the genesis was for thinking. And, frankly, in my classes, I've asked the question of my PhD students recently, who is neurotypical? Give me a definition of what that means, neurotypical. And in my opinion, in my interpretation, in order to give a definition, it's very easy to get into rocky waters of bias, of prejudice, and stereotypical labels, right? And misperceptions that go along with all of those lexical issues around what are the words we use to describe differences in speech and language and communication. Okay, so that was part of it. And I looked at a variety of sources. One of the sources, and I'll be doing some old-fashioned paraphrasing, and occasionally I will actually read excerpts because I've been doing research on the topic, and some of those that are experts on this can say it better than I can. So I will, when needed, I'll give you some quotes. But one of the recent textbooks that I looked at was or a book's recently released in 2021. It's called Introduction to Social Justice in Speech Language Pathology, just released last year by Ramonda Horton at Midwestern University. And in the introduction, the author talks about the history of our behavioral science discipline, speech language pathology. For those of you who know, it was essentially an offshoot of the field of psychology. And we have focused in that area specifically on implementation of techniques that change communication behaviors. So we look at communication as a behavior. If we are following, well, at least historically, we looked at communication as a behavior that was to be modified in clinical settings. Our definition and our scope of practice has broadened since then, but those are our roots. And so our profession is rooted in human services. We have focused on practices that aim to enhance or remediate a person's communication ability. We aim to improve communication skills for individuals on a one-on-one level or in a group setting to try to improve quality of life, generally speaking. And we're doing so in context and environments of those individuals' homes and communities. However, we see some barriers in this process, following discipline-specific knowledge and communication to try to create this change. And one of the barriers is, as a field, we have persistently failed in really directly discussing harmful and unfair institutional and systemic contexts in working with those we serve. Only recently has this become a topic in the field of communication sciences and disorders, which would include audiology or hearing sciences and speech language pathology, speech therapy, and rehabilitation. Okay, so our discipline really has very rarely considered ways in which ideological orientations, practices, policies, curriculum, and training models can actually reinforce marginalization. And so we have an increased likelihood in the current practice, if we don't reflect back on our roots and our terminology that we use, we are definitely at danger for perpetuating and contributing to larger societal injustices with our students, with other professionals, and with our stakeholders who have been minoritized in society based on a label or healthcare diagnosis within the field of communication sciences. So Levy and Seidel in 2013 talked about social injustices as denying fundamental human rights, economic, social, cultural, or political. In speech pathology, the broader impact on society and how we view communication and human behaviors are all intertwined with what we know about learning and socialization and psychology. So, in order to be effective and be culturally responsive in modern day practice, we have to consider social justice issues and try to delineate some of those socioculture factors and sociopolitical contexts that influence equity and justice. So we're getting into that's sort of a beginning of looking at a summary of approaches and perspectives and terminology that are commonly used in speech pathology and audiology. All right. So we're looking at labels. We'll be talking about misperceptions and some of the resulting negative outcomes, divisiveness, inequity, minoritization in the field of communication scientists. And we'll talk about how our terminology has perpetuated some negative stereotypes and potentially contributed to excluding individuals from social environments. At this point, I also wanted to mention in speech, language, and hearing sciences, we're becoming increasingly aware of structural racism and inequity and injustice in our professions. We're beginning to analyze historical, political, and cultural influences, but without looking at the concepts involved, it's very difficult to make a lot of headway if we can't agree on our basic terminology. So that's the other side of why I thought this might be a good talk today. Oh, there we go. Okay, so again, why are we focusing on terminology? Terminology, of course, is critical in our scientific, professional, social, and media-based communication. We're beginning to reflect greater awareness in 2022 of individual differences as a society, as a whole, and the value of the individual experience, inclusion, and existence of social justice issues. However, the concern, again, is traditional labels that can accompany stereotypes, as cited, with Epstein and others. Click on the right page here. Now, historically, I'll reiterate that we've had very little discussion of socially just approaches to speech language pathology. The elephants in the room are, of course, potential for feelings of exclusion. Oops, didn't mean to do that. Sorry. Some of my, I'm noticing some of my subheadings aren't showing up. I believe that should say isolation, and the second image on the right pertains to exclusion and stereotypes. So we've had very little discussion over the past 2 decades. However, there has been a move to promote cultural competence in speech pathology programs to try to improve the quality and effectiveness of our service delivery, so that in terms of working with clients from diverse backgrounds. And ASHA, the American Speech, Language, and Hearing Association, has previously put forth an agenda to address cultural competence, and their definition of cultural competence in 2017 included 3 components, which would include 3 training efforts for training of new providers. Number 1, teaching students and practitioners how to be aware of clinician-client mismatches and identify personal bias. Number 2 would be establishing a knowledge base on the impact of socioculture factors on language and communication in various populations. All right. And the third one is developing a service delivery skill set for implementing what they called least biased assessment procedures, vaguely defined, and culturally sensitive interventions. So part of the challenge and the issue, although we have been moving closer to cultural competence and cultural responsiveness, going back to 2017 and up until today, we have been a little bit stuck with a cultural competence model that is not well defined and does not give us clear guidelines about the terminology we use, does not give us clear guidelines, and we have not had clear discussions about what does that mean in terms of how do you define a service delivery skill set that is least biased? What does that exactly mean? We don't have a good handle on that as a community of professionals. So my goal today is for us to have a deeper analysis of the language that we use to talk about variability in human communication, and talk about a little bit, just give some examples and go through some basic examples that I came up with where we have unintended consequences of the terminology we use, an unintended division of groups, stakeholders, and in particular, diverse or marginalized communities that tend to end up lumped into a minoritized category of end users. All right. So this is a concern, and what I want us to do is try to strive to do better and look at some basic examples and think about, okay, this is the current state of the art in terms of terminology and how we understand communication differences, but how can we move forward and find new ways of describing and relating on a real individual basis and really focusing on those individual differences that we haven't always been keenly aware of, and we certainly are not well versed in addressing individual differences when it comes to specific diagnoses. So I want to talk about the fact that terminology can perpetuate social exclusiveness, that we can unintentionally, with the words we use, be promoting differences and promoting negative outcomes. But on the other hand, we have an opportunity now to focus and consider ways that we can promote greater understanding, inclusion, equity across the range of communication, and communication heterogeneity. And specifically, my examples will touch upon deafness, autism, selective mutism, aphasia, race, ethnicity, and SES. All right. So again, reiteration a bit of the historical basis, but so that we are clearly on the same page, speech, language, and hearing science constructs, it really evolved from early on from educational models of labeling and sorting students into categories for special education services. And so from the get-go, we were creating a minoritized class of students throughout our educational system. And things didn't get much better when speech pathologists moved into the healthcare model, which also, follows or maybe even you could argue more intensely, follows a prescriptive approach based on a medical diagnosis. And so now we can talk about, well, for our speech pathologists and audiologists working in different settings, in one setting in education, we have one set of terminology that may be acting in an exclusive way, in a discriminatory way, or a stereotypical way. And then we have another set of terminology and actions and objectives and consequences that exist in the healthcare world based on not only minoritization, but also medicalization of this is your condition. We will diagnose this as a medical subcategory, and we will address your case based on checking all of the boxes that we tend to look for diagnostically, and then therapeutically, same idea. We're going to use a term that you have not been involved in creating for yourself, but as a medical community, we will hand you a label. We will give you a label, and that will be your ticket or your pass to various medical services. And it may be, on the other hand, it also may be a limitation for you. So it may give you a passing go into specific medical services, medications, and so on. But at the same time, what's the downside of the label? What's the downside of the diagnostic category when we're talking about an individual patient who may not exactly fit into a one size fits all approach? So we need to be more and more aware in both medical communities and healthcare and education. So common keywords we need to think about: medicalization. Are we over medicalizing our terminology, or talking about individuals as a diagnosis instead of talking about them as individual human beings? And on the same side, in education, are we talking about students in education as an educational placement label, or are we really seeing the individual person and their individual characteristics, strengths? And we know how important it is to think about a strength-based approach with so many of our interventions today. We don't strictly, in the field of speech pathology, follow only a behavioral intervention strategy. We now are opening up into more holistic strategies that address the whole person, the sensory motor system, mental health, family-based interventions and parent-based interventions, and so on. However, we have not taken into consideration and gotten really good at adapting to individual communication differences in the same manner that we think about in medical settings when we think about a medical diagnosis. In other settings in speech pathology, we may give a one size fits all for outpatient services or even family-based services that occur inside the home. So we sometimes give lip service by using terms like family-based services, when in reality many of those family-based services are very cookie cutter in nature, and that, again, I would argue, goes back to our narrow diagnoses and narrow-minded labels that we have been accustomed to using. So another factor that we need to lay out is in educational settings. For sure, we know historically that we have disproportionate representation of marginalized individuals, marginalized groups. Specifically, Black and Native American males tend to be over-identified in learning disabilities programs, attention deficit accommodations and programs, autism spectrum, and so on. And we are becoming more sensitive of the fact that these programs and labels can be highly stigmatizing in terms of terms like intellectual disability, emotional disturbance. And we know that in other students in the system are under-identified on the other side of the basket, according to Robinson, Norton, and others, Sullivan and Sullivan. Asian students, for example, under-identified across disability categories without any other explanation other than an Asian label. Okay. So we have, having said all of that and talking about educational models and a little bit about healthcare models of identification, diagnosis, rehabilitation, and so on, I also want to recognize today that there are changing sociocultural models and programs. However, our history, according to Venekatasen, I have some great quotes from Venekatasen. The history of communication disorders has journeyed from magical religious conceptualizations through biological medical approaches, which I've been talking about, to the contemporary rights-based paradigm wherein the person and environment is emphasized. So we're making strides to think about the person and environment, at least in 2018 and forward. However, we're still defining what that means. I think I had some other notes on this. Venekatasen also has some great descriptions and comments about the concept of normality, and how the concept of normality has adjacent layers that would include things like abnormality, subnormality, paranormality, and these types of terms classify and categorize people into a variety of hues or colors. And we know that differences, disparity, and dissimilarities are all part of our existential reality, and our social systems, according to Venekatasen, are created in part to serve the typical in mind. So we have a built-in bias based on the terms of normality versus abnormality versus subnormality, or below normal or paranormal, that creates a built-in bias, and we need to be aware of that in our clinical settings and in our educational and academic settings. My mouse is giving me trouble. Okay, there it goes. In addition, let's see. In addition, we know that racial, ethnic identity, class background, language spoken, disability status, gender identity, and sexual orientation can all influence the level of privilege or oppression that exists with our clients, with our students, with our practitioners. So we talk about being aware of intersectionality and the idea that individuals experience multiple different forms of oppression potentially and prejudice. And so in terms of speech pathology, these same concepts apply. We want to consider the consequences of our individual clients' social positions, and the positions that they find themselves in educationally and socially and economically, that can impact outcomes over a lifetime. And we have to move this. Our disability advocates have noted that attitudinal, environmental, and contextual barriers posed by this medical model of disability reinforce the concept of ableism and practices that go to reinforce prejudice or discrimination against those with disabilities. So this is nothing new. However, what is a little bit new is thinking about these consequences within the field of speech pathology. And as I've said, we have had a little discussion about socially just approaches. Heider in The Power of Words talks about terms and concepts being the basis of thought and being critical to understanding individual differences. And within speech, language, and hearing sciences, we have concepts that have essentially outlived their usefulness and really probably need to be updated. despite the fact that we are continuing to use outdated terms and becoming aware as a field and as a profession that our concepts and terms can perpetuate oppression and exploitation. I think I had, make sure I hit everything on that one. Right, so the other comment I wanted to make on that slide was we're working towards understanding and changing institutionalized forms of oppression, and trying as part of this workshop is to hopefully influence others to think about producing better outcomes for individuals and communities who have been historically marginalized. So we'll begin exploring some terms. Let's see. All right, the first terms are minority and minorities, those terms themselves. And we can think about and research alternatives. One of the new alternatives, according to Cocoyd and Seeger, for example, is using the term global majority. Instead of using the term minority for a group of individuals, global majority represents this concept of individuals who are in the majority in the world individuals of color being the majority of people in the world. So this idea that how can you be a global majority and be labeled a minority, something that we need to consider. Okay. Some other terms I wanted to look at, and feel free to jump in where we'll go through these terms, and at the end we can go back and discuss particular terms. And you all, I would love it if our attendees can think about their ideas about these terms and maybe alternative terms or concepts that we might begin associating. So that would be great. Pathology. So speech language pathology within its title includes the word pathology and has been so for a very long time. I have personally been approached by clients from the deaf community, individuals from the deaf community, who have a hard time understanding why is this academic institution calling my condition pathology or disorder. I'm a deaf person. I'm part of deaf culture. So this is, and I have a language, a bona fide language of American Sign Language that exists as a separate cultural phenomenon. And so these terms themselves, this idea of, well, I'm deaf, I have to go to the speech pathology department to get my services, or I have to go to the communication disorders department to teach a sign language class, for example. This can be particularly damaging to deaf and hard of hearing individuals. It includes deafness under this umbrella of disorder, which takes away individual agency and really disrespects the long legacy of deaf language and culture. So we have this hyper-stigmatized situation that also occurs, beyond the deaf community, but also with dialectal variations, stereotypes and discrimination based on regional accents or local accents and dialects. Also falling under this umbrella term sometimes without even being intentionally included under the umbrella term, but the existence of our speech language pathology programs and communication disorders programs and the way that they are named in and of itself creates a hyper-stigmatized environment for individuals who maybe want to receive accent reduction or accent modification services. These would be, within speech pathology, these would be considered elective services. Also with stuttering, cluttering, and other speech differences, the idea that we know going way back, we have come made some progress with diagnoses like stuttering, where in the past stuttering was considered a psychological or psychiatric condition, and we have moved to we moved to understanding that stuttering is a speech condition. But the use of the terms pathology and disorders may, really, in my opinion, may hyperstigmatize. And I'm wondering if we can find other ways of talking about, for example, fluency differences, for example, for stuttering, and really, baking into the cake the idea that fluency exists across a continuum, the ability to speak fluently, and we have some pretty shaky diagnostic criteria for identifying what the difference between a person who stutters is versus a person who is not diagnosably a person who stutters, and that those criteria can change, and the interpretation of the data can change from day to day and week to week depending on what kind of day that person is having. So part of what I see the question in the chat, I'll just go there in a second, but part of what I would like to see us talk about is the idea that, conditions like stuttering may be perceived along more of a continuum. We talk about communication skills across a continuum of neurodiversity. We can talk about communication skills in terms of neurodiversity, but not necessarily in terms of neurotypical versus neurodiagnostically different, and so on. So let me see I think I may have a question in the chat. Okay, someone says, yeah, thank you. They do have a negative connotation. Josie tells us, I think referring to pathology and disorders. Is that right? So I personally,
yes, that's right.
Thank you for your comment. I personally believe that we have fallen into a bit of a trap in using these terms because of the kinds of reactions I've actually had from, real live individual clients and families. Who wants to go to the speech pathology clinic or the communication disorders clinic when maybe you just want an elective service, or you feel like, hey, I want to improve my communication skills, but I don't feel that I I need to be included in this label unnecessarily. All right, so I think I spoke my piece on that slide.
I like the way you described that. I want to improve my communication skills.
Oh, right.
It's a totally different approach, right?
Well, that's my question. Have using these terms obviously there's been a functional reason and functional benefits that are for the convenience of speech pathologists, so that we can categorize just like we make a diagnosis in a medical community for a particular medical condition, and then that indicates a certain type of intervention approach. But the more we learn about intervention approaches, setting the medical community aside, particularly in something as complex as communication, there's so many factors that involve your speech production and your language production that go beyond just a simple label or diagnosis. Those labels are convenient, as a clinical tool. However, from a public relations standpoint, they're a nightmare. And from a truly meeting the clients and finding a space of respect and a space of, okay, we're all in this together. Everyone has neuro diversity within them of some sort. Can we take a more holistic approach and use more holistic terminology? I don't know. Maybe I'm being overly idealistic, but I would like to think that we could make some progress in any case in how we describe ourselves and how we describe the individuals that we work with, and really start. One thing we haven't done very well either is ask our clients, what would you like to be called? How would you describe your condition? How would you describe your communication experience? Would you rather talk about it as an individual communication difference, And we don't even have to use terms like strengths and weaknesses. We can just talk about what are your goals, with a strength-based approach. What is it you want to achieve with your communication, or what you want for your family member? So, and we have intervention practices that follow those types of philosophies, but we still are chained to old terminology. And so even if you're very modern and holistic in your orientation, we're left with terminology that's just our day-to-day. This is how we speak, because we haven't examined the terminology. Is my point. The term poverty, some have said, and I gave a citation down at the bottom here. For example, a Crane, Heider, and Salas Provence. The term poverty may hide the cause of one's impoverishment. So we talk about, perhaps instead of saying a person who experiences poverty or lives in poverty, we can focus on terms like impoverishment that don't allow us so easily to think that perhaps the impoverished person is in that state by their own fault. And we have long-running negative stereotypes about poor people, and this negative stereotype that laziness must be a factor. Whereas with impoverishment as a term, that is more open-ended and gives us a better sense that there are other factors, or numerous potential factors, that are involved in poverty, such as economic factors, political factors, social injustice, inequity. So the idea that we can think about impoverishment as a state of, as not a steady state, but as an experience that has been placed upon a particular individual, could be really powerful. I'm just having to move my screen around. Okay, so of course we need to discuss autism. Many of us have talked about changes in the terminology with autism spectrum lately, with advocates within the autism community coming forward and saying, hey, I want to be identified as autistic. I do not want to be referred to as a person with autism, which traditionally 20, 30, 40 years ago, when those of us were trained, who have been practicing for a while, the idea of person first language had the intent of person first respects the person first, and then you are able to add the label as a secondary point of context. So we talked about individuals with autism, right? Individuals, or a person who stutters instead of saying a stutterer, or a person with a cleft palate, what have you. And then we have seen, very interestingly, certain communities have stepped up, like in the deaf community, and said, no, I'm proud of my culture. Being deaf is not a disorder to me. Being deaf is part of my culture, and it's part of my identity. How dare you say that I'm an individual with deafness? Don't you dare say that, because individual with deafness implies, that I have a medical problem, or that I'm less than in some way, right? Same idea with autism. Now we're seeing the language change, where what we used to say, individuals with autism, we have many folks in the community saying, no, just say, Jerry is autistic. That's part of who I am. That's part of my experience. I want you to be straightforward. And so we're now beginning to respect and hear. That's one example, at least, where we have done a pretty good job listening to our clients about what they want to be called. And that's wonderful. But historically, we used the term autism spectrum, which got us into trouble as well, because this creates a category of individuals that, again, don't fit a cookie cutter label, but we're talking about a spectrum as if it's a single entity, when in reality we have so much variety in what individual differences look like with autistic people. It's hard for me to even say that because I was trained not to say that. But now autistic people is considered, or the idea that being autistic doesn't have to be associated with a negative stereotype. And that's part of the misperception that people have had. Oh, okay. And the idea that autism represents a type of neurodiversity. This idea is becoming, more and more popularized and more accepted, and really has been the canary in the coal mine of how do we deal with terminology and respecting individual rights and how they want to be referred to and addressed. Also autistic, the idea with the term, just using the word autistic by itself is meant to reveal that depth of experience. Member in a larger community, yes, but respecting those individual differences, not that everyone who is autistic has the same experience. And that the idea that the spectrum idea doesn't really come into play, right? Spectrum is a larger category that doesn't necessarily say anything about the individual. There's a question, are other countries similar in the terminology? That's a good question. Let me think about that for a couple of seconds. I do have some experience overseas, and my first gut response is that I know in some languages communication differences are the terminology isn't as specific in some languages as we have in the English language. So I don't have a full answer to that, but my guess would be that in some circumstances, at least, that in the English language and the level of specificity that we have found and created, that we may have a bit more of a problem in English, but I'm speculating a little bit there. That's, if anyone, when we get to this discussion, if anyone wants to add to that, that would be wonderful. Is autism becoming less of a stigma? Definitely, autism is becoming, certainly, in my opinion, is becoming less stigmatized. And part of that has been really a movement of parents over the past 40 years who advocated for their children. And they were parents that had a high social status. They had many advantages, which is why their voices were heard easily. They were parents that were wealthier and had money to advocate. So I believe autism is a good example where, and I have no, this is not, telling any secrets out of school. We know that awareness of autism is where it is because parents spoke out and put their money on the table and made things happen. Okay. So, on the other side of that, I want us to recognize individuals in other groups or with other communication differences who have not been so lucky, right? So selective mutism is one of those examples. And we'll get to that in a second. That may be the next slide. That may be the perfect transition. Let's see here. I think it is the next slide. No, that's okay. I'll skip ahead. I'll improvise. Selective mutism is a condition where individuals have difficulty or are not able to speak in certain situations due to social anxiety. And the term selective mutism was meant to clarify that the mutism was not a choice for the child. Before being called selective mutism, this diagnosis was called elective mutism. Many folks feel that selective has not adequately clarified the situation because it gives the impression that the child is selecting not to talk. So you have a child who is not speaking at school. The term is selective mutism. not speaking at school, not speaking on the playground, what have you. And then the perception is, oh, this child is choosing not to speak, when nothing could be further from the truth. The child wants to speak, but is involuntarily frozen due to a fight, flight, freeze response, literally frozen in fear. This is a neurobiological condition. This is not a condition where the child is refusing to speak. And so we have negative stereotypes about children with selective mutism being willfully mute, being willfully disobedient. And so this has been a problem for a long time. And going back to the autism term, selective mutism is not nearly as well understood, and has not had that same kind of advocacy, wind at its back experience that autism had. Although selective mutism is increasing in prevalence, it's about 1% of the population at least. It's a difficult number to really be sure that that's accurate. But we know because it's an anxiety-based condition, it's increasing along with all the other anxiety disorders. So selective mutism will likely, I hope, fingers crossed, receive better public awareness in the near future, because we're seeing more and more cases every day of selective mutism. But at the same time, we can probably do a better job with that term, in my opinion. Other terms that are being used already in the autism community, situational mutism is used for autistic individuals who also have moments where they are selectively mute. However, they cannot technically receive a dual diagnosis according to diagnostic policies and rules. But they can end up with autism plus situational mutism. And that might be a term that better suits children who are affected by selective mutism, because then we understand, okay, this is a situational problem. This isn't something that the child is misbehaving. This is in certain situations where the anxiety level spikes, and typically that's going to school for the first time, preschool, kindergarten, and so on, being overwhelmed by the social demands, and the anxiety that comes from that creates the selective mutism. Perhaps thinking of it as situational mutism is helpful, or even the term temporarily non-speaking at least gives the impression that this is not a permanent condition, and that the child has the ability to speak, and that it's not because of the child's own willfulness not to speak, that they are temporarily incapacitated or temporarily unable to speak. So there are other terms that are being tossed around in the community that may or may actually be better than what I have here, I'll fully admit. But I really like the clear-cut directness of temporarily non-speaking, at least. And we could talk about two different things too, right? We can talk about, these are diagnostic labels that maybe we still need, but in our everyday conversations, how can we frame this differently? Can we talk about, how can we teach our families and our teachers and our providers, to not use the term selective mutism all the time, because it's not very helpful in clarifying what the actual experience is. What's more helpful in clarifying what the actual experience is? Oh, my child is temporarily non-speaking. Oh, okay, that I understand. That is more of a layperson's explanation that makes sense. And sometimes we make trouble for ourselves coming up with fancy labels that are less descriptive of what the experience actually is. Let me go back to, I think I already covered this, but I want to make sure I didn't miss anything. This idea of neurotypical, neurodiverse, I'm questioning this because I'm worried that this promotes a false dichotomy, that there is something as normal versus abnormal, and that these are really just substitute words for normal versus abnormal. So I'm worried about that. I would rather see us moving away from stereotypes and confusion around, neurotypical versus neurodiverse. I would rather have a more holistic way of communicating this and expressing that all human beings are unique and neurodiverse. So this is a different mindset. So even going back to communication differences or disorder labels, how can we think about uniqueness, neurodiversity as step one in understanding our individuals that we work with, and then go from there, rather so more of a top-down approach to thinking about individual differences, then bottom up and looking at, well, okay, what is category does this person fall into, and then immediately structure everything around that. So I think there are opportunities, and particularly like in counseling scenarios and educational settings where we can do a better job, even if we're still legally and policy restricted to the terms that have been in place for decades. We can begin moving in a different direction. Already went over selective mutism. This story about Bruce Willis came out recently with a diagnosis of aphasia. Immediately what happened in social media and in other media sources was a mischaracterization of what aphasia meant. It got lumped in with other memory and cognitive problems like dementia and Alzheimer's. Even my mother called me on the phone. She said, "What happened to Bruce Willis? Does he not have normal intellectual functioning?" And I said, "I don't know, Mom. If he has an aphasia diagnosis, that doesn't necessarily include a memory problem or a cognitive problem or any impact on intelligence whatsoever." So as a term, this is sort of a recent example I wanted to give that was out there in the media, and I don't think it's been clarified. I haven't seen it really clarified yet, partly perhaps because the family isn't wanting to release the details of Bruce Willis's condition. But using the term aphasia doesn't give us a whole lot of information in this example. We know that aphasia means without language. If you're in speech language pathology, you're a speech therapist, then you understand there are different types of aphasia. And so it might be that there's some difficulty with speech production, but that comprehension and understanding and all other cognitive functions are intact. But we don't know because we have a misunderstanding where the word aphasia is not commonly known, right? So this is one of those terms, again, where we have very low public awareness of the term aphasia. So I might suggest some alternatives that could be used in the media, things like speech output difference without voice for individuals who are not able to speak verbally. There are any number of other possibilities. Those are the possibilities that I'm sort of putting forth. But this was a really great example of where ideas got twisted, misperception, and that just had a huge trickle down effect in social media. So now I'm worried that we have many thousands or millions of social media consumers believing that aphasia and Alzheimer's disease are the same thing, and that's absolutely nothing could be further from the truth. So I worry about terms that are not readily understandable to the public, and that's one of them, aphasia. Again, understanding that we need terms that are professional terms that we can all communicate with. However, we need to do a better job finding alternative terms, at least in our descriptions, in our media releases, and so on, so that the public can begin to understand what the real experience of these different communication processes are. Let's see. We're at the reflections point. I wanted to, at this point, quote the famous philosopher Oprah Winfrey, who said the greatest discovery of all time is that people change the world by merely changing their own attitude. And I think that's important for us as we reflect changing sociocultural models, terminology, policy programs in rehabilitation for people with communication disorders, thinking about this concept of normality, the idea that society has historically thrived on this idea of equality and normality, and it may be okay in some situations. I don't even necessarily agree with who was that? That was Koretsky and Simmons talking about, it's okay to discuss typical versus normal footwear. And to me, that doesn't add up either as an analogy. But the idea, the point that that does make sense is thinking about this idea of typicality, and the idea and the unfortunate result of, if you have a concept of typicality and what that means, that differences tend to be destroyed or misunderstood or even obliterated, because there's this concept of individuals fitting one particular mold who are falling within a stereotype of normality, whereas persons with disabilities are considered different, perhaps lesser than, perhaps the old term a handicapped person, or if a person who is versus a person who is, or even a person who identifies as having a disability does something normal, and then the reaction can be that this is it's a miracle, or this is a superhuman characteristic, when really it's just part of that individual's individual differences and strengths and weaknesses. So if that makes sense. And the problem with stereotypes being that they implicitly or explicitly influence self-perception of our individuals, our clients, our families, our stakeholders, our friends, and also the perception of the people around them. So this is where the situation is, rife with misperceptions and stereotypes. All right, so I believe that's the end of my prepared material, and I'll open it up for questions, comments, discussion. Thank you for listening and throwing questions up into the chat room. I appreciate that. I see no questions currently in the chat. Does anyone have any comments? Let me see if I have anything else I can. If we don't have comments, I can toss out a couple of generic questions if necessary. But we had some good comments. What do you all think about this idea of how we use terminology and how it affects our perception of individuals? Anybody have any thoughts?
I think it's very interesting. I mean, this has been a really interesting talk, and Jen given me a different perspective. And I think that, when you think about diversity, equity, and inclusion, how do we change what we call things? I realize that there's the diagnosis piece of that, right? And that's for the practitioner to be, to utilize. But how do we get society to change the dialect of how they describe some of these in a way that is more neutralized and doesn't make that person or people around them feel like they're less than, or, I don't know. This has been very interesting. Thank you.
It's a difficult problem. It's certainly challenging. I certainly don't claim to have all the answers or solutions, but I think that's okay. I think that's where we are. I think we're at the point of, we're beginning to recognize that our interventions can be better and are getting better with recognizing, individual differences. My concern is that we're tied to terminology in some cases that's outdated and no longer serving us as well as we would like. So I believe, terminology, we know terminology changes over time. But what I would like to see is more folks advocating for change in our terminology, at least within speech pathology and audiology. Oh, another thing, might be another conversation sparker. A recently, ASHA asked for feedback on the name of their annual awareness month, and historically, I forget how many years. I think it's been definitely over 50 years. We've had Better Speech and Hearing Month. The month of May is Better Speech and Hearing Month, and I wrote a letter to ASHA indicating my opinion that speech, language, and hearing are not a competition, and that by talking about better speech and hearing, we are first, obviously excluding the deaf community right off the bat. So if better speech and hearing is the goal, individuals, who are hard of hearing or deaf, and part of that community and experience, that's not their goal. Their goal is not, in some cases, that's a broad statement. But now that we have cochlear implants, yes, many cases we have improved hearing as a goal, but that's certainly not true for 100% of our deaf individuals. We have this whole deaf community that would not prefer to be hearing, even if they could, because that is their identity, that is their community. You can ask them, would you rather be a hearing person? No is the answer for a large segment. So this idea of better speech and hearing being a comparison, I don't like. I suggested that it be called, I think it was Communication Differences Month, or Awareness of Communication Differences Month is what I think. And I think that would be a huge way to begin this conversation on a national level, so that we can start saying, what's the goal of May is to understand, the month of May in our field is to understand how everyone communicates in a different manner. And then we're moving away from that diagnostic label. Even though we may have to continue in our daily practice to use those labels in a particular manner, right? We can still have another goal that meets the clients at where they are as individuals and creates a whole new communication space for saying, look, I respect you, I see you, I understand that these are your individual, this is what makes you unique, and I'm interested in that, and I care about that, and I recognize that, and I don't care about this diagnosis over here, even though we might have to use it for insurance purposes. So being able to communicate that, I think, is so vital in the future, as we go move into the future of being, truly more culturally responsive and more individual personality responsive. I think that would be huge. So I hope if they don't take my recommendation, hey, everyone write a letter to the American Speech, Language, and Hearing Association and tell your friends. If they don't get enough people like me, they'll just think I'm crazy and nothing will happen. But if we get enough of a grassroots movement to give them this feedback that better speech and hearing, think about individuals who have a speech condition that will never improve, that has already improved as much as it can. Well, all of those people are excluded from Better Speech and Hearing Month because their speech will never get better. Does that mean we throw them away? Does that mean that we don't recognize them as a field? I think it's ridiculous. So I feel strongly about it. Let's see, there's something in the chat for me. And somebody said, I never thought about that. Better Speech and Hearing Month. Yes, yeah. Well, and I'll tell you the good thing. The fact that ASHA even put out a poll, that tells us we're making progress. Because that's never happened before. ASHA has never asked, hey, what do you think about this the name of Better Speech and Hearing Month? So I don't know for sure the politics and the background, what happened behind the curtain, but I do know that ASHA has been, the ASHA leadership has had their feet held to the fire in the past few years for not being current enough in terms of cultural responsivity, making truly sensitive and knowledgeable statements about what's happening in political and uh, social context and current events. And so it's great that folks are giving Asha feedback and that Asha is responding. So I think we're lucky to be in a time now where the terminology is in flux, and we can all hopefully contribute and make some positive changes. So those are my. Oh, do I have a question, Rosalind? Do you have a question?
Yes, I do, and thank you so much for mentioning about the Better Speech and Hearing Month. I get things in my email, so I'm always aware when May comes around, and
Drives me crazy.
I never thought of that. So thank you for bringing that to our attention.
Oh, you're welcome. It is being questioned, so that's a good thing.
Yeah, that is a good thing.
I feel
so I have a question for you. Want to sort of pick your brain a bit, and thinking about the global majority, and are there terms that you believe that would help change things for, say, well, I guess I have so many questions. So one, and then you can select which one. I'll just kind of maybe pick two for you, but I have tons. But one would be for Indigenous males and Black males here in the U.S. Are there ways to help? You showed the slide earlier. Are there ways to help to bridge the gap? And I mean, like, I take it that perhaps their parents aren't ones that are, getting in there and trying to make the change because perhaps they don't know enough. Are there ways to communicate within those communities so that the parents can be better advocates for them, and even more so, the speech language pathologists can be, advocates for these boys? And then, so you could tackle that one, and then the other one, well, I'll just give you that one, I guess, maybe. Yeah.
Well, sure. I mean, I actually teach the law and law policy and advocacy class, and we speak every week about ways that we can try to advocate for specific marginalized groups. And one of the projects I have for my class is I ask students to create a case study where they promote or they choose a particular individual and develop an advocacy plan for that individual. And so I am very much a proponent of looking at the entire person. So my first answer is I want to be careful in answering that question by not over generalizing anything with reference to, boys of color and indigenous people, right? So what I ask my students to do is to look at what are the various challenges, first of all, that the individual faces. So some of those challenges might be racial bias, right? Discrimination. Mm-hmm. Some of those challenges might be even lack of access to equitable healthcare or racist or negative treatment within the healthcare system or within the mental health care system. And we have documentation that exists. So the first step is understanding what is the reality of the individual on a number of levels. I'm just starting with racial because you brought that up, but we can talk about racial. We can talk about what are the economic challenges and being fully aware that economics and race and culture are intertwined in the United States, but at the same time dissecting what's going on economically, what's going on, what are the educational or academic challenges, what are the social and emotional challenges, what are the individual parenting and family challenges, perhaps, and sibling, that would include siblings. So looking at the individual within the context of the family and what are all of those forces that are creating challenges, and then trying to go from there. So I don't have a one size fits all answer for, you know, people of color and indigenous, you know, boys at risk, for example. But and that those are many specific issues that we could go into. Did you have a specific like challenge or issue in mind that you were thinking of?
Well, in a way, yes. I think about, well, I live in Santa Barbara, California, and where Fielding is. And, you know, I noticed that a lot of the boys and girls of color rarely have access. One, they're being diagnosed late, and if at all,
Right.
or as
Okay.
your slide showed, you know, over or
Right.
under.
Right.
And so I'm just wondering, like, if there's like language that when speaking with communities. So I think I mentioned I'm on the board of Right Care Childhood Language Center
Mhm.
here in town, and the speech language pathologists do an excellent job, you know, but they can only reach so many, and then it's
Yeah.
really difficult to reach a lot of times those the BIPOC community, and
Right.
just trying to figure out like how do they, you know, how do the parents advocate? How is it to be able to get to other SLPs to help them to, you know, I don't know if it's individual or if it's like the industry itself, you know?
Yeah, there's so many ways I can go with that. So
Yeah.
you know, one way is to look at the state data and the district data, because for federal funding, schools have to report the breakdown by race in special education services,
Hmm.
and that's how we know that there's a disproportionate percentage, right, of, you know, individuals um, from marginalized groups in special education. Um, so part of it is being aware of what is happening when the rubber hits the road, right? And what, and then looking exactly what are those programs that are being provided. And in some cases, I mean, and within the, and beginning with the notion that the system is broken in most places.
Hmm.
System is broken to a point where, and you mentioned speech pathologists doing a great job. So you have um, an eligibility system that is often very broken, and you see examples where the heroes in the community are getting kids placed for services like speech and language services. They're not doing so in a manner that really is accurate, or and in a way that uses a label that's even accurate. I've seen
Hmm.
districts, for example, that um, essentially um, put an autism label on all the preschoolers who are English language learners, who are, you know, bilingual or multilingual, and kids with any individual differences. And many of those kids are language and speech delayed, who come from communities of color, right? So you have so you have the providers trying to work the system in a way that, so that they know that those children need help or individual service, but the way that they get labeled is completely, really unethical and illegal. And
Mm.
so there's no simple answer to any of this. But knowing, but part of what you need to know is, so for example, what parents would need to know is, what are the services you're getting and what are you fighting for, right? That's huge. You know, so
Mm.
if you have a child, maybe you have a, so I'll use that scenario, right? You have a child who's placed and labeled as autism, but they're getting services for speech and language, and they're getting additional, related services that are helpful to them. Are you going to fight the label at that point? Is it worth it to fight the label? Probably not. But that same child, 2-3 years down the road, then it may be a very important fight, because that child is not on the autism spectrum. They need services of some kind if they continue to have problems. But then we need to do a better job explaining to parents and families how to navigate the system, right?
Yeah.
So what are you getting? Are you getting what you want despite the label? Okay, maybe we can live with that. But when does the label become a barrier for your child? And at that point, and helping parents to understand, look, if your child is in a special education program for more than 2 or 3 years, and it's a full-time intense placement, that's probably not going to change very quickly unless you get involved and try to figure out, is that really necessary, or is it a one-size-fits-all program that's actually detrimental to the child's development?
Wow. Yes.
I don't know if that answers your question, but it was a big question.
No, I mean, just to hear, it was, and I just really wanted to, get some insight from, I appreciated your presentation and the way that you explained, your thought process and such. So I really just wanted to hear, like some of your thoughts and see how things are working, and
Right.
I'm so glad to hear what you're doing with your students, like with that one particular assignment.
Right. And the idea is they take an individual child and really make an individualized plan, which is what our special education system is supposed to be doing. However, and that's another thing that we need to help our parents and families understand, an individualized education plan is only as individualized as it is created, right? It might be overly generic, and parent involvement is huge, and creating, and then, so another big issue is parents who are struggling in impoverishment, economically and socially, and perhaps with mental health or other issues or health issues. Those are going to be families that have less ability to be involved with the educational system. So then you have this balance between the therapists and providers at school trying to do the right thing, in some cases without any parent input or very little parent input. Important for us to understand that's not the parent's fault, number one, but also important on the other side, what can we do to give parents the resources so they can be more involved, make it easier for them to be involved when they don't normally have the resources to do so. And so things like just reaching out, pamphlets, brochures, reaching out with get to know you nights, that are beyond the typical just come to school and or whatever, home visits. I've seen home visits can be super powerful. I've seen communities where the school staff just take it upon themselves to go to individual families' homes and help them out, help them with if they have a problem, if they have or just getting to know the child, or getting to understand the family better and their culture. That can be huge.
Yes.
But that requires the usually extra time and investment from the teachers, and we have a major teacher shortage and many teachers bailing out of education because of the way they're being treated within the broken system. So the broken system certainly needs to be addressed, but beyond that, we can do things as individual providers to make a huge difference in those lives of those individual children.
Yes, and yes.
I think.
I agree with that, most definitely. Yeah, just because the system can use some more development does not mean that on an individual basis that things cannot be done. So glad to hear.
And you have to be so aware, right, as a provider or as a case manager or whatever, you have to be so aware we're talking about the labels that are inaccurate, and then that's one problem. But then in the reverse direction, what about all of the children who are not getting identified for services because they don't meet an arbitrary eligibility requirement? So it's that's sort of a separate issue, like, the way systems the way systems and institutions define eligibility and diagnosis and label, that's probably not going to change too much anytime soon. But I'm hoping that the pressure comes from the providers themselves and the families themselves, just the way it did with the autism community, that we get a broader base, kind of a groundswell, grassroots movement, if you will, for providers and families to say, wait a minute, the system is one thing and eligibility is one thing, but the way that we meet our parents and families halfway, we have control over that.
Yeah.
So I think it's important. It's important because you don't want to exhaust yourself trying to change a system that is not changeable in the current moment, but at the same time find ways to work within the system and advocate for change. And it's always a challenge. It's an ongoing thing, and it's difficult to keep that momentum going, particularly in the pandemic era, and economic instability and political and social instability. It's difficult to stay positive. Part of what we talk about in my class is how do you keep up your own momentum. And part of that is finding little pockets within yourself or within your own communities. And today was my pocket. This was what can I do? I'm not going to change the world in one day, but I can do a talk at that Fielding Graduate University and get the word out about thinking about educational labels, and specifically speech pathology labels that are probably pretty outdated. Thanks for your questions, Paulson. Those were great, and your enthusiasm.
Oh goodness, you're welcome. You're welcome.
I love it.
Great. Thanks.
And honestly, this is an area I'm new to as well. I've been in the field for a long time, but for me to really reflect and think about what can we do to change our terminology and our perspectives, I fully admit I plead ignorance on having all of the solutions, but I do think I see what